Good afternoon, everyone. Welcome to today's Research America Alliance discussion. I'm Erin Darbuz, the Senior Director of Policy and Advocacy at Research America, and I'd like to thank you for joining on Zoom today and for your partnership in the Research America Alliance. If your organization is not a member, I hope you'll reach out to Joel, our Director of Membership, whose email is in the chat for information about the Alliance. In recognition of Autism Acceptance Month, we are pleased to be joined by Dr. Cheryl McNeil, professor in the Department of Psychology at the University of Florida. She will discuss parent-child interaction therapy for autism spectrum disorder and its broader application for other complex behavioral dynamics. As always, please type your questions into the Q&A box or chat, and we'll get to them during the audience Q&A portion of today's session. Thank you so much for joining us, Dr. McNeil, and over to you.
Okay, I'm very excited to be here and share with you about the work that I do here at the University of Florida. So I'm going to go ahead and share my screen. So today we're going to be talking about a treatment called parent-child interaction therapy that I have devoted my decades-long career to researching. And I want to talk some about the clinical features of this and the research as well. So what is PCIT? When you're thinking about preschoolers, their disruptive behavior disorders kind of come across like a pot of soup. And it's kind of hard to distinguish which ingredient is which. But a typical young child with some behavioral concerns has a bit of hyperactivity in there, some temper tantrums, some aggression, and some defiance. And it all comes together to cause a fair amount of stress for the family. And if you look at mental health issues with young children, you're going to see that ADHD is a big chunk of what we deal with in the mental health world. And then behavior disorders like the aggression, the tantrums, the oppositional behavior, that's also a big chunk. So over 50% of what we deal with is disruptive behavior. And then when you add autism spectrum disorder on that, then we're getting to about the 2/3 level of referrals are usually for autism, behavior disorders, ADHD, that sort of thing. So in my career, when we started out, we did PCIT with what was called behavior problem children, children that displayed that aggression, the defiance, and that sort of thing. Over the years, PCIT has expanded and now has a strong evidence base for autism spectrum disorder as well. But the hallmark diagnoses for PCIT, the first one is oppositional defiant disorder. And there's the DSM criteria listed there, defying adult requests, losing temper easily. But I have my own little assessment that I call my water bottle assessment that you're welcome to use if you're wondering if you're working with a child with oppositional defiant disorder. And that is that if you have a whole bunch of children in a big lecture hall and you say to them, there's only one rule in the lecture hall, you're not allowed to touch my water bottle. The children with ODD will actually come to you because the most interesting thing in the room will be the water bottle. I'm going to touch it. What are we going to do? What are you going to do if I touch it? And there's this interest in being in charge and seeing if they can break the rules and the stimulating value of breaking the rules. With PCIT and its parallel version called teacher-child interaction training, where we work with teachers, we get a huge change in child compliance, which is the hallmark of oppositional defiant disorder. So in order to understand this graph, I just want you to imagine a preschooler and imagine that you gave that preschooler 10 things to do throughout the day. How many would they do the first time you told them to do it? And what we find is that typical children will do about 62%, about 6 out of 10, when you tell them to do something like go get your shoes or pick up that doll or come to the dinner table. But the children who are referred for parent-child interaction therapy will usually only do 1 out of 10. So most of the time they're saying no, they're saying you do it, I don't want to, wait a minute, or they're arguing. After PCIT, the intervention is highly effective for child compliance. That children, after they go through the parent-child interaction therapy evidence-based program, they will comply with 7 or 8 out of 10, which is better than your average child. So PCIT is really strong for oppositional defiant disorder. And what you'll see it on a measure called the IBER Child Behavior Inventory, which is a standardized measure of behavior problems, you will see that with PCIT, there's a great decrease from the clinical level above the 95th percentile to after PCIT, they come within the normative mean. So they actually look like their peers. They look like other 5-year-olds after PCIT. This is what the parent reports in terms of how much aggression, arguing, whining, profanity, things like that, that they're seeing in the child. PCIT also was originally designed for conduct disorder or early onset conduct disorder. This is a little cartoon where a little baby is stealing the bottles and says Bobby's infamous career as a lunch money extortionist could be traced back to his earliest days as he's stealing the little bottles out of the nursery. What we see with conduct disorder is that the children steal, they lie, there's destroying things, and there's kind of a sneakiness in rule breaking. And that's what we typically think of as juvenile delinquency. But before you see that sort of problem in as teenagers, you can often see signs early on that children are breaking rules and having some problems with authority early on. The third diagnosis we work with a lot in PCIT originally is ADHD, attention deficit hyperactivity disorder. Children are on the go, difficulty sticking with tasks, difficulty waiting their turn, very impulsive. So now what has happened in the last 10 years is that PCIT has expanded beyond those externalizing behavior disorders of ADHD, ODD, and conduct disorder. It has expanded into the world of autism, anxiety disorders, depression, and trauma. And we have an evidence base for most of the mental health concerns of young children. So what's defining about PCIT? What makes it unique? The first thing that's unique about this is that you're working with a parent and a child together. So you're working on that relationship between the parent and the child. They're bringing their child with them into the clinic. And if you have two parents, the two parents come together with the identified child. And we're coaching, usually from behind a one-way mirror, but sometimes over telehealth. Sometimes we're coaching in the room in someone's home, or we're coaching in the room with teachers in the classroom. And so what we're doing with coaching is that the parent's got a Bluetooth on their ear, and we're usually behind a one-way mirror. And we coach the parent on exactly what to say and exactly what to do as their child is misbehaving in real time, or maybe they're behaving appropriately in real time. We tell them what to do as if a therapist was in the room. What would a therapist do if their child was hitting them? What would a therapist do if the child was spitting or running out of the room? And in this model, we coach the parent on exactly what to say and do to manage those behaviors as they are occurring. Let me just show a video just to kind of get us started here. And I think this video is going to help you kind of get a sense of what this looks like. And this will be with a child who's on the autism spectrum. And you can kind of take a peek here at what PCIT looks like when you put it all together. So let me do this for you. Alrighty. Here. I'm just going to share my screen. Let's take a look at this video. Here's PCIT in action.
It's hard as a parent to see your kid struggling. We had been having some behavioral challenges with Gus, both in school and at home. And I felt a little bit helpless because I didn't know how to make that struggle easier for him. When we came to Sunfield the first time and we met with Susie, I remember at the end of the first visit, her saying, "I think we can help you."
I'm Dr. Susie Naguib. I'm the clinical director at Sunfield Center. As parents, we all want our children to be happy, to be confident, caring, and well-adjusted. Parent-child interaction therapy, or PCIT for short, is a treatment to help parents improve their relationship with their child while using positive parenting skills and effective disciplinary strategies, and helps children learn to follow directions in a predictable and nurturing environment. What's unique about PCIT is that parents practice new skills with their child while receiving live coaching through an earpiece from behind a one-way mirror. Yes, that's exactly what you do.
PCIT is done in 2 treatment phases. The first phase involves teaching parents a set of positive parenting skills that have been proven to create a warm and secure parent-child relationship.
I like that you're being so creative and flexible with how you use the Legos.
The next phase of PCIT involves teaching parents how to give effective commands and use disciplinary strategies in a consistent and predictable way.
Please hand me 4 white blocks.
What we find is that as parents continue to practice, their skills improve, as does their child's behavior.
Once we started learning the method that Sunfield uses, we saw pretty immediate progress with Gus. We still had some challenges, but it felt like he was more in control, and our relationship with him just felt so much more positive. And that just made our home life almost immediately easier. One of the things that they ask us every week when we come is what percentage of directions is Gus following? When we first started coming here, 10% of the time. And now when we come most weeks, it's 100% of the time. It's a night and day difference between when we started.
PCIT is an evidence-based treatment. It has been heavily researched and found to be effective in helping families. Every family that completes treatment is considered a treatment success. Treatment ends when parents have perfected and mastered their skills, and the child's behavior has significantly improved. What is wonderful about this intervention is that at the end of treatment, we can look at the child and the parent in the eyes and see that we've made a long-lasting impact.
The Sunfield Center really impresses me because of their dedication.
I'm going to stop right there, and it kind of gives you a feel for that we are coaching from behind a one-way mirror. We're helping the parent to know how to manage behaviors in real time while they're occurring. So let me tell you a little bit more about PCIT. And that was a little boy on the autism spectrum that you were seeing, and the parent was feeling like, when the parents feel like, I don't know how to relate, I don't know how to get them to play with toys appropriately, the coaching would help the parents to work on things like eye contact, to work on having a relationship where you can play together, talk together, and that the child wants to engage with the parent. The treatment is theoretically grounded, and it's in behavioral theory and attachment theory. It pulls a lot from play therapy in terms of forming a relationship in a really intense and positive way with a child very quickly. Another theory that is under that is the basis of PCIT is by Baumrin, and that's Baumrin's parenting styles. And what we're aiming for is we're aiming for this perfect balance called an authoritative parenting style, where we work on increasing the warmth in the relationship and also increasing control. So we want to have this perfect balance between relationship and limit setting. And we teach parents both parts of that in the PCIT model. One of the defining features of PCIT is that it is a short-term program. It usually lasts about 14 to 16 sessions, but it is not time limited. And the reason it's not time limited is because it's assessment driven. Rather than the parent saying, well, I think I learned the parenting skills, we actually code them using a coding system called the dyadic parent-child interaction coding system. And we code the caregiver every session, and then we chart their progress towards what we call the goal criteria. And the goal criteria are set very, very high. And so there's an expression that says, if you're aiming at nothing, you're certainly going to hit it. In PCIT, we are aiming at a very high standard for the parents. Let me just give you an example. One of the skills of PCIT is labeled praise. That means tell the child exactly what you like about what they're doing. And in PCIT, we don't teach that skill a little bit. We get parents to over practice it to the point of habit. So in order to hit the goal criteria, the parent has to give one of those labeled praises every 30 seconds for 5 minutes. So that means they're giving 10 labeled praises in a 5-minute period. And you think about, when's the last time as a parent you gave 10 labeled praises to a child in 5 minutes? And so what we're doing is we're over practicing to the point of habit so that it spills out the rest of the day. And we have these parents doing a 5-minute play session using basically play therapy skills with their child every day at home, and then doing the skills at an extremely high level, like the level of a therapist, and then allowing those skills to spill out during the rest of the day. So it's not a time-limited intervention. It ends when the parent has hit the goal criteria for their use of the parenting skills, when their parent ratings on something like the IBERG Child Behavior Inventory or the Child Behavior Checklist or the BASC, when the ratings come to within normal limits, so that the parent is no longer expressing concerns with aggression or tantrums or oppositional behavior. And when the parent says, I've got confidence, like, I don't think I need this Bluetooth in my ear anymore. I think I got this. I think I can do this on my own. That's when PCIT is over. So PCIT is designed for little kids between the ages of 2 and 7. So they're for the preschool age range, but we do have a PCIT toddler version for 1 to 2-year-olds. And we have expanded it to a PCIT older child version for 7 to 10-year-olds. But that's about as high as we've gone with the model, is up to about the age of 10. Another distinguishing feature is that parents are not blamed when they're coming in, but they are given responsibility for improving the child's behavior. So it's a pretty sensitive topic for a parent to call in to a counselor and say, I don't know how to manage my child. It's a brave thing to do. And when that happens, if a parent gets referred to parent training, it can come across as judgmental. Like, here's your average parent and here's you. And you need to go to like remedial classes to get up to the level of your average parent. In PCIT, we're not aiming for average parenting at all. We're aiming for therapeutic parenting or specialized parenting. So your average parent is here. We're trying to create super parents who have the skills of a behavior analyst, or the skills of a psychologist, the skills of a special education teacher who specializes in behavior disorders. So we're having the parents come in, the caregivers, and we're coaching them on how to be a behavioral expert for their child. Some defining features of PCIT come into the research of it. There have literally been hundreds of controlled studies of PCIT. And again and again and again, across populations, it shows across the world, it shows that the parents do change their skills. They become more positive in interacting with their children. The behavior problems come to within normal limits. We get maintenance at 2-year and 4-year follow-up. We get generalization to the school, where the school behavior gets better when we just work with the family. We have generalization across a lot of different populations, like autism spectrum, separation anxiety disorder, childhood depression, things of that sort. The effect sizes are some of the highest that have ever been seen in the field of mental health and psychiatry. So if you take all the hundreds of studies that have been done on PCIT and you come up with a standardized effect size between 0 and 1.5, and you standardize that effect size, a small effect size is like 0.1 to 0.2. That would be like a vaccine. 0.3 to 0.5 would be like aspirin for heart attack, like a prevention model. 0.6 to 0.8 is a very large effect size, and that's what you would get for like a stimulant for ADHD. And then depression medications like Prozac are 0.9, around 0.9 to 1.0. In the PCIT world, we get effect sizes up to 1.45, 1.57. On parent changes, we get up to 5.67. This is a meta-analysis that collapsed the effect sizes across hundreds of studies. And those effect sizes are astronomical in the field of behavioral health. And so we get gigantic changes from outside of normal limits to within normal limits after a program that lasts, 14 to 16 sessions. So it's about 4 months, about once a week for about 4 or 5 months. The way that PCIT runs is you start with an assessment where we observe the family in 3 5-minute situations: child-led play, parent-led play, cleanup. We get our measures ahead of time. Then the parent comes alone and we teach them what's called the child-directed interaction. And those are the positive parenting skills that are based on play therapy and attachment theory. Then they're also very behavioral in terms of reinforcing certain behaviors to get children's behavior to improve. We also, then we spend several sessions coaching the parent from a distance, from telehealth or from behind the one-way mirror, coaching them as they interact with their child. Then we have them come back and we teach them what's called the parent-directed interaction skills. These are the discipline skills that are based on scientifically proven discipline techniques for what do you do when your child hits another child? What do you use when they use, what should you do when they use profane words or they're arguing? And so the discipline techniques were designed from scientific research. Then we have the parents come in, we coach them in setting limits with their children in real time. So when they're setting limits and the child attacks them, we tell them what to say and what to do to get through setting a limit with a child who gets pretty dysregulated when they're told no. Then we do a post-treatment assessment and booster sessions as needed. So the majority of time in sessions is spent coaching the parents as they interact with their child. So that's what we spend the most time doing. We code every session, and the parent is given feedback on how their reports are coming down or going up about their child's behavior and how their skills are changing over the course of the intervention. And then they're given homework every day, but it's only 5 minutes a day typically, where they're told to go home and practice these techniques in a play situation with their children. So let's just go over the first half. This is what they do for the 5 minutes a day in the child-directed interaction. These are the skills based on what we've learned over many decades of research on play therapy. So in play therapy, your child is brought to a therapist, and a therapist has only moments to form a deep relationship with that child, so that a child, say with a trauma history, or a child who's having severe panic attacks, or is very dysregulated and upset. You have only a short period of time as a therapist to form a relationship with that child so they feel comfortable telling you what's going on with them, talking about their feelings. The basic skills of play therapy were packaged in a way that they could be taught to parents. And so there are 5 skills that are called the do skills, and they spell out the word pride. We call them our pride skills, and we teach the parents the pride skills. And during that play therapy session, we teach them to avoid commands, questions, and criticizing, like the words no, don't, stop, quit, and not. For 5 minutes a day, they are to follow their child's lead and provide pretty much unconditional positive regard to work on that relationship. When the relationship improves, the child wants to please their parent. And once they want to please their parent, setting limits and having rules and getting them to listen to you becomes a whole lot easier when they're very eager to make the parent happy and to please their parent. So we spend about 6 of our sessions working on these positive play therapy skills and improving the relationship. Another major skill that we teach is ignoring annoying and obnoxious behavior. We teach parents to underreact when a child is engaging in negative attention seeking. So why does a child use profane words? Why do they whine? What's the purpose of it? What's the function of it? And for most of the disruptive behaviors, challenging behaviors that you see in children, attention is a primary reason for a lot of those behaviors. And so the use of underreaction or ignoring can help a lot. Even in the case of ASD, when you're talking about self-injurious behavior, a lot of times that has an attentional component to it as well. So parents need to get comfortable with the idea of removing attention, because attention can be very reinforcing, and to use it in a systematic way. So they remove it very temporarily for a few seconds. They wait for a positive behavior, return the attention, and then use these wonderful pride skills to reinforce the behaviors they want to see more of. So the 2 phases are the child-directed interaction, the parent-directed interaction. And in the parent-directed interaction, there's a big focus on teaching parents to be consistent and predictable and follow through with their rules and their expectations in the home in a very calm, robotic fashion, where you take the negative attention and the yelling and the stimulation and things like that out of the discipline approach, because children who have a lot of challenging behaviors can be reinforced by attention and escalation. So we need to make sure that parents stay super calm, super regulated, and we work on the warmth first, and then we work on the limit setting with a particular emphasis on compliance training. So the discipline component then really focuses a lot on this control aspect and teaching parents how to give effective instructions to their children, how to notice, did the child comply or non-comply when I told them to do something? So a parent is taught to give an instruction in an effective way, a short instruction, very clear, and then they're taught to stay quiet and watch and point. And when a child complies, to reinforce it with what we call a labeled praise, telling the child exactly what you like about what it is that they're doing. So that whenever you give a labeled praise, boy, I love the way you picked up your toys when I asked you to. So we teach them to notice compliance and make sure it gets a payoff. Because if a behavior is not getting a payoff, it will go away. So we want to make sure that parents are aware when they're giving an instruction, that they gave an instruction, stay silent for 5 seconds so a young child, particularly a child on the spectrum, has a chance to process what it is you're asking of them. And then use a gesture, use a point so that they know what it is you're wanting. And then stay quiet, watch, and when they do it, give an enthusiastic praise, a hug, a touch, and let them know that you appreciate it when they follow your directions. So let's talk a little bit about ASD and why this would be helpful for children on the autism spectrum. With PCIT, it has the strongest technology currently available for transferring skills from a therapist expert to a parent. And that transfer of skills occurs through the coaching approach and the over practicing of skills to the point of habit. And now research is showing in study after study after study that the same effects that we get for PCIT with ADHD, PCIT for oppositional defiant disorder, PCIT for conduct disorder, PCIT for trauma, child maltreatment, all those same effects are occurring with autism spectrum disorder as well. So this is kind of an emerging area of research for PCIT. And that research is summarized in this book that I edited on the Handbook of Parent-Child Interaction Therapy for Children on the Autism Spectrum. one of the things we do in the child-directed interaction part of PCIT is that we make social attention more reinforcing to the autistic child, so that we teach the parent to relate to that child in a way, following them, watching their cues, and relate to them in a way that the child begins to want to pull the parent into their world, rather than wanting to be isolated, wanting to be in their bedroom, wanting to be left alone. We're getting the parent to be highly reinforcing in play and talk, so that the child seeks that out and is really enjoying the verbal and play attention of the parent. Let me just show you a video from some of our research that will kind of give you a sense of what that's about. I'm going to pull up another video for us. This is a preference assessment that we did. In this preference assessment, let me just make sure this is working real quick. Okay. It's fine. All right. Sorry, I'm going to pull up this and make sure that you all can see it. 1 second. There we go. I'm going to share my screen. Okay. So this is a child on the autism spectrum at the pre-treatment of PCIT, engaging in a preference assessment. And in this preference assessment, the parent is on one side of the room with a set of magnetiles. The same magnetiles are on the other side of the room. And we're seeing, and there's a line down the middle. Does the child prefer to play with their parents, or do they prefer to play with the magnetiles alone? I'm just going to show you a child here. This parent has given permission to use this video for teaching purposes. So I thank the parent and the child for their assistance.
On this line, you get to play with some toys now. Mom will be on this side with that toy, with those magnetiles, but the same exact magnetiles will be on that side all by itself. Both of the sets are exactly the same. My friends
I'm gonna play with that one.
My friends and I are gonna be watching you play, but you can pretend like we're not here, okay? So pick one side.
So this would be at pre-treatment, the day 1 assessment. He chooses to play alone.
Pick one
with
side.
the toys. On day 2 of the assessment, he chooses to play alone.
Pick one side.
On day 3, given his preference, he
Pick
would
one
rather
side.
play alone than play with his parent. This would be day 4
Pick
of
one
our
side.
assessment. And day 5 of our assessment, he just prefers to play alone in his own world.
Pick
And
one side.
here's at the mid-treatment assessment. He has a choice to play with mom and the magnetiles or just the magnetiles, and he chooses to play alone. This is after we've gone through PCIT. And this is where he's been playing with his mother 5 minutes a day using play therapy skills. And now he wants to include her in the play.
Pick one side.
This is the second assessment point after he's gone through PCIT.
Okay.
Mom is now more.
That's something cool.
Pick one side.
He wants to interact. He wants to play with his mother.
Pick one side.
And so now the parental attention has become more reinforcing to this
I
child.
love you.
Oh, I love you, baby.
Pick one side.
Playing alone isn't so fun
Play with these
anymore.
toys.
He says, play with these toys, play with me, Mom.
Pick one
He wants to
side.
play. And then this is what happens at 3 months after we finish the program.
Pick one side.
He still wants to be with his mom.
Mom, play.
He wants to
I get
play
all
with her.
these
He wants to.
toys now. This one's super cool.
Pick one side.
And so that's, you just get a sense for what we're dealing with here. And you could say, well, Cheryl, why is that important that a child wants to play with their parent? But when you're talking about autism spectrum disorder, one of the key features is that the relationship issues and that ability to have a reciprocity in relationships. And so by focusing on that, PCIT is adding something to the typical milieu of services for autism, which tend to be a little bit more therapist working directly with child. And in PCIT, we add to that. That's important that you have therapists working directly with child, doing language development, doing all sorts of man training and direct trials and things like that to increase a child's repertoire. But PCIT adds the relationship part where the parent wants to know, what do I do? How do I get my child to listen? How do I teach my child? How do I work with my child? So I'm going to go ahead and go back to my slides and just go through a few other things here. Sorry, let me do this one more time. Just going to go back here. So one of the things we do with children on the autism spectrum is that we do focus on compliance training, getting them to do what the parent says to do. Because with compliance, it's like a gate. It's like opening a gate to all sorts of skills training and the education and learning and social communication. Because if the child won't listen to the parent, if you can't get them to come to the table, you can't get them to work on tying their shoes, because you can't get them to come or to do the tasks of holding the shoelaces, then they can't learn. So we really focus on getting the child, when a parent tells them to do something, to listen right away. And we have seen the same changes in children on the autism spectrum, with improvements from about 30 to 48%, 3 out of 10, 4 out of 10 at the beginning of treatment, all the way to 80 to 90% after PCIT. And you could hear that mother, she was saying that he's complying about 100% of the time after he goes through the intervention. This is a study that we did of PCIT with children on the autism spectrum, and we used the Eiberg Child Behavior Inventory, which is a measure of the parent saying, how many times does my child argue, refuse to listen, hyperactive, screaming, things like that. And at pre-treatment, you can see across 3 participants, we did a multiple baseline across 3 participants. The Eiberg Child Behavior Inventory goes from, this is the normal limits line. So it goes from, that's the clinical range line. It goes from clinical levels all the way to within normal limits in terms of challenging behaviors that are seen in the home after PCIT. It goes to within the level of normal limits. In the open trial pilot of PCIT by Zlomke and colleagues, there were 17 children with ASD in this one, and they had about 19 sessions. And 19 sessions is about 19 hours of therapy. That's really a small amount in the autism world, because with typical services, applied behavior analysis, speech therapy, they tend to have several years worth of therapy. So to have a small add-on of PCIT to those services is pretty cost effective in the big picture, because it adds only 19 hours of services to the hundreds of hours that the children typically are expected to receive when they have special needs. In this particular study, the compliance improved 46%, from 41% to 87% across the 17 children with autism spectrum disorder. So that means just bringing that to down to the level of a parent. If a parent says it's time for your school, please put on your shoes, the child would say, okay, mom, and then please come to dinner. Okay, dad. You can imagine how your life would be so different if 8 out of 10 times your child was saying okay and doing it, instead of put them on, get your shoes on, we got to go, get your shoes on, and you're getting that non-compliance. It's really challenging to raise a child who is not listening to what it is you're telling them to do. One of the things we've expanded to in the last 6 years is the opioid crisis, and using PCIT to help with the opioid crisis. So I've had a grant that's a state opioid response grant in the state of West Virginia. In the state of West Virginia, the overwhelming majority of children in foster care right now are there because of substance abuse issues, so that the families have lost custody of their children because of substance problems like opioid use disorder and things like that. So what happens with children whose caregivers are victims of the opioid crisis is that the children are often displaced. So they often go to grandma's house and stay with grandma for a while, and then they go back to biological parent, and then they go to foster care for a while. And there's a lot of misplacements. And the children often have some compromise to the nervous system that may have happened from the use of substances during pregnancy. And so you've got a child who might have some special needs neurologically and developmentally, and they're put into a situation with trauma and changed placements. Sometimes they're raised by grandparents, and they tend to be very active and have some challenging behavior. So PCIT has been a really helpful intervention for grandparents, kinship care, foster parents who are working with some children who have some pretty significant mental health concerns. Here's some references in terms of some of the books on PCIT and where some of this comes from. And I think we're just going to stop there and make sure we have time for some question and answer.
Wow, that was a fantastic presentation, Dr. McNeil. Thank you so much. I would like to ask a few questions that came to mind as you spoke.
Sure.
So, what are some signs that indicate parents should seek professional help? And following after that, once they do receive the PCIT therapy, parents' behavior is modified as well as the children, but can parents post-therapy distinguish between, modifying behavior and compliance and child's, natural kind of autonomy and self-expression?
Yes. So when you know that you should probably seek out some extra help is when your home life is really impacted and the child's day-to-day functioning, the ability for them to be able to grow and learn and have friends, all of that is being negatively impacted by the behavior problems. So if you're feeling stressed all the time because there's constant screaming, constant fighting, constant hitting, constant defiance, and your quality of life is just really poor and the family time is really impacted, you probably want to think about getting some extra help with how to handle that. And then in terms of the child's autonomy, I think PCIT has this beautiful balance where we spend half of the time in therapy working on following the child's lead through the use of these play therapy skills. And in that, you're really supporting their autonomy. It's very strengths-based. So they're using these pride skills. So the parent is learning to reflect back everything that the child is saying using active listening skills. They're learning to imitate the child to show that I love what you're doing so much, I'm going to do it too. They learn to use selective attention and behavioral descriptions to really, the child is the center of the world. And so the relationship is there, the ability to follow is there. And then they also learn that in those times when you need to take charge, that you can feel certain that your child will listen. If you're in the parking lot of Office Depot and you say, take my hand, you need to know your child is going to do that. Or if you're in a situation where the child is learning to toilet train or they're learning to write their name, you need to be able to be in charge and have a child who is going to be responsive to guidance. So I think that PCIT kind of balances that warmth with that control pretty beautifully.
Wow, that's great. Thank you. And we'll take a question from our webinar chat. Vanessa asks, do you have any data on PCIT in autism spectrum disorder children who have a PDA profile?
Can I get more information about that?
I think PDA is the pathological demand avoidance profile. But Vanessa, if you have more clarity, if you want to type it in the chat.
The reason I asked for that is because the PDA profile really maps onto oppositional defiant disorder. And that's the child who does not want to listen to what the parent is telling them to do. And so I think that most of the referrals for children on the autism spectrum involves a co-occurring oppositional defiant disorder, which I think is PDA. I think those two things are, they overlap.
Okay.
Yeah.
And our last question that we have time for will be from the Q&A, just asking if in the future there will be a similar PCIT program for children 11 to 15, during puberty.
Oh my goodness. Wouldn't that be great? That'd be fabulous. It definitely does not exist right now because the program is so developmentally specific to younger children because it's play-based. So all of the interactions are play-based. So I would love to see that, but I wouldn't even know where to start with my focus on early childhood. I wouldn't even know where to begin, but I'd love to see someone develop.
Maybe some video games or
yeah,
playing
maybe
at the
so.
ball.
I get out with the basketball hoop. I don't know. I'm not sure how to do that. Yeah.
All right. Well, thank you so much. This has been an amazing conversation, but it looks like this is all the time we have for today. And thank you again, Dr. McNeil, and thank you to the audience for your thoughts, your participation. Check out our Alliance discussion page on the website for the next discussion. And thank you again for joining us today. And we look forward to seeing you again soon. Have a great afternoon. And thanks again, Dr. McNeil.
Nice to be able to talk with you all. Thank you all.